power is given unto
Check 1, 2.
Check. One, two. 1, 2. Check 1, 2. Check 1, 2.
That's coming from here, which should be your feed. This was that, and I've silenced it, but I've let you know it killed my code line.
Check 1, 2.
Yeah, so there you go. That's the room.
Check.
Give your phone when you see if you hear it anymore on the.
I'm listening to it on my earphone.
You still hear me not right now?
The song.
Check 1, 2. Check 1, 2. Oh, that's good. I look better. Yeah, 1, 2.
Ladies and gentlemen, I want to give you a 2-minute warning. So if you want to get some more of that delicious food, you can do it. But please don't stop eating, but we will start the program in 2 minutes. Music will all start singing. Ladies and gentlemen, good evening, good evening. We can go ahead and get started. I'd like to welcome you to the Caregivers Conquering Cancer, Advancing Health Education and Equity in Multiple Myeloma. It's a wonderful program that is set up for you, and we'll be getting started. But first, let's have a couple of welcomings, and we'll have first Pastor Morrison. Please, if you could come up and get things started for us, sir.
Thank you. Good evening again. These 2 days for our community. Um, Health. What we do not do enough of is inviting our community in. And so this is something new for us, and we're excited about these 2 days. We've been able to partner with the Hill Collaborative. When I met Howard, it was a blessing because he was offering something that had been on our hearts to be able to do. And so we're excited about hosting you. We hope that you enjoyed the meal. Please feel free to make sure you don't go to sleep now. And if there's anything we can do for you while you're here, ask any of our members, any of our staff. We're glad to have you. God bless.
Thank you very much, Pastor. Thank you very much. While you're in the mood to clap, you've got to give a hand to the folks. Been doing a little informal survey. How many of you eat dessert first and then go on? Let me see the first. Okay, we got 1. I know we got 2 and 3 over here. 4. Okay. I didn't realize that was a real thing, having dessert before your meal. That's pretty good. I guess the pastor was the dessert. Mr. Howard Mosby, who's the corporate treasurer of Hill Collaborative. Mr. Mosby is a former Georgia State representative from the 90th District, and he's also a Georgia State University grad. I hope I got it right this time, sir. He's Georgia State University. Couldn't be at Howard.
Good afternoon. What time is it? Evening. That's right. It's almost 7. Good evening. Good evening. First of all, my name is Howard Mosby, and I am, as you heard, the corporate treasurer of HEAL Collaborative. Our organization really is built around how do we bend the curve on these diseases that have chronically affected communities of color, specifically African-American communities. So today we're going to be talking about multiple myeloma. But before we do that, first of all, I want to thank Pastor Morrison. So let's give it up for Pastor. Now this is your pastor. He's my friend. I was referred to Pastor Morrison by a good friend of mine, and she said, if you're going to do a program in Atlanta, go to Shaw Temple. I said, Shaw Temple? Aren't they downtown? She said, well, I don't know. I'm not. She was out of D.C., Connecticut. She said, I don't know. And so we talked to Pastor Morrison, found out you guys used to be downtown Atlanta, and you moved out here. And so what I thought I knew was correct, and it was also incorrect at the same time. But I want to say thank you, sir, for opening up your house, inviting your family here to hear this information around multiple myeloma. It negatively affects African Americans more than white Americans, and we need to know about this. You might not be directly affected by multiple myeloma. I guarantee you in your circle, somebody is. And this is really about each one teach one. And if you do have this disease in your family or you're carrying it, this is the time to really get this information and ask your questions. Now, the reason why we're doing this here at Shaw Temple, how many of y'all like Pastor Morrison? Do y'all think that he would bring somebody in here that you can trust, that you can ask the questions that you need to get answered? So there are no dumb questions in here. There are no inappropriate questions in here. You ask what it is that you want to get answered in this space. We have brought some of the most dynamic professionals to come here to bring you information around this space, and we do this intentionally so that you can get trusted information and you'll be able to ask these questions. So that's what we're here to do. Now, we could not do this if we didn't have Kite Pharmaceuticals behind us. Kite, we're the Kite people. I know Rolando's he's gonna talk about this, but I just want to say formally, thank you for backing us to say, this is the community we want to do business in. This is the community we want to bring this information to, and you stood behind us to make this happen. So with that, ladies and gentlemen, I want you to buckle up, because you're getting ready to get some awesome information. So ladies and gentlemen, I'm gonna turn this back over to Dr. Tuckson. Now, he is crazy, but he is ours, and we love him. So thank you.
Thank you, sir. I appreciate that, sir. Let's formally recognize the folks from Kite, a Gilead company, but Kite Pharmaceuticals. Let's get Kathy, stand up. Lisa, Allie, stand up, stand up. I want people to see and recognize. If you got a question, you can talk to them. And I want you to just think about this for a moment, if you will. How many pharmaceutical companies, representatives, and higher-ups have you ever met? Okay? That's how important this is. Thank you all very much. Thank you, thank you, thank you. We appreciate this. This is a two-day conference, so today is going to be part one. Before we begin, please, there are surveys in your programs, in the pamphlets that you were given. Fill out the pre-survey. At the conclusion of the program, we want you to fill out the post-survey and evaluation. And tomorrow we're going to do the same thing over again. Now, but please, it is very important to us because the information that you provide gives good feedback on what we're doing, how successful we are, and where we need to tweak the program to make it a little bit better. This program is entitled Caregivers Conquering Cancer, Advancing Health Education and Equity in Multiple Myeloma. As you heard, it's here, hosted at Shaw Temple, African Methodist Episcopal Zion Church, but it's also being streamed and will be available if you want to look at it later online. So I do encourage you to do so. Take advantage of this. The real question comes down, yes, sir. He's going to be introduced later. I didn't forget him. Yeah. He wanted me to introduce Rolando, who's going to be up here running one of the programs, but he's bashful. He didn't want to be introduced twice. No. But over the next 2 days, we're going to try to shed a little light on a disease that, while it only affects 1%, just think about that, just about 1%. Generally, it's about 1 in every 108 Americans is diagnosed with multiple myeloma. But the problem is, you've already heard, it has increased incidence in African Americans. In fact, it's more common in African Americans, and in particular, African American males more so than anybody else. So it's an interesting problem. Though it's only 1%, that seems real small unless you are what? One of them 1%. Then all of a sudden it's the most important thing and the biggest thing in the whole wide world. And that's why we're here, because we want to make people aware about what's going on. Let me tell you, there are some prominent individuals who've been diagnosed with multiple myeloma, including Ice-T. I don't mean the drink. Ice-T. Ice-T is kind of an anomaly. He was diagnosed while he was in his 20s. Normally, as we'll hear later, most people tend to be a little bit older. Then there's the rapper coming out of New York, who I know is a good friend of yours, Christina, Guru, diagnosed and died multiple myeloma. Then there's Bruce Springsteen's wife and bandmate, Patty Ciofala, never say her name. She also is a multiple myeloma. And for those of you who remember NBC News anchor Tom Brokaw, who's still alive, but was diagnosed with multiple myeloma back in 2013. So the things that we're going to cover today, and let me just say, this is not just about patients. It's about the caregivers, because as Kathy was saying to me earlier, nobody goes through this thing alone. We have our team with us. I don't mean the physicians and the nurses and all that, but I mean our family members. Though that team part is important, that team is important too. So today we're going to be talking about the patient and family experiences when we have our fireside chat, which I think is very important so we can hear what it's like from the patient's perspective, which is far different from what physicians and other caregivers may think and say. Talk about the incidence of who's getting multiple myeloma, what are the precursor conditions, what are some of the things that may be happening before the formal diagnosis is made, what are the signs and symptoms, and how you go about making an early diagnosis. Who gets treated? When do you start treatment? And what does the treatment look like? What are the options available to us? And then something that is very important and has really changed the shape of who's surviving and not surviving with multiple myeloma. When is CAR-T, or CART, which is CAR-T cell therapy, used? What point do we get into that? And then back to this thing about the theme of our program. Helping the patient and their caregivers to go through the obstacles and the course of treatment and the disease itself. And finally, we're going to talk a little bit about some of the mechanics of how do you go about developing a new medication. I don't know if you've ever thought about it, but it is not one of these simple things you go on the shelf, pull out a little thing, and start giving it to people. It's very complex, from thought to development to testing. So we're going to have a little bit of that. So there are a lot of good things that are going to happen to us. But first, before we do that, now I'd like to bring up Mr. Rolando Enoch. Mr. Enoch is the Director of Clinical Operations, Diversity and Inclusion in Clinical Trials with KITE, which is, again, KITE, a Gilead corporation. Give us a welcome, and we'll hear more from him in a little bit. Thank you.
Thank you, Dr. Tuckson. Good evening, everyone. Again, my name is Rolando Enoch, and I'm so excited and thrilled to be here with Shaw Temple. I don't know, after Pastor Morrison, Dr. Tuckson, and then Howard, I feel like we need to pass the plate, you know, but no. I mean, thank you, Dr. Tuckson, for going through the agenda. We are here and going to share some very important and informative information. But one of the things that I did want to share was, I love the question that Howard asked. How many times have you met people from a pharmaceutical company that are in your community that are actively trying to bring forth good information, the right information, talk about options, talk about, you know, to share with you the reality? Not many, right? But it's something that I'm very proud of, the company that I work for. I've been with KITE almost 6 years this year, and I've seen some amazing things. Oftentimes we hear about the misnomers and the mistrust and just all the negative things, but there are some wonderful things that are going on inside of the four walls of KITE Pharma, I can say, certainly. I have been in this industry for quite some time, but I have had a wonderful career. But what we're doing tonight is what drives me. It's what I'm so passionate about. Being out in the community, partnering with trusted community leaders and organizations such as HEAL Collaborative, again, to bring forth the truth. Because as we know, the truth and the light, to get us far, right? So again, welcome. Thank you so much for being here, and I'm really excited. And again, ask us questions. Come talk to us. We're here today as well as tomorrow. All right? So thank you.
As I said, I'm going to introduce the fireside chat panel first, and then we're going to go to the next part. So Ms. Gail McCrae. Ms. McCrae is a multiple myeloma patient and I am from IMF Atlanta Southside Support Group leader. Mr. Ted Price. Come on up, Mr. Price. Mr. Price is a multiple myeloma patient advocate. And his better half, he brought his daughter with him, Ms. Maddie Price, who is a multiple myeloma caregiver. I may look stupid, but I ain't crazy. This is going to be our chat. But before we get to that, we have a video presentation that has been prepared for us. And let's take a look, because this is going to lead us into our discussion.
Did you know that multiple myeloma is the most common blood cancer among African Americans? Multiple myeloma disproportionately affects the African American community. African Americans may get diagnosed later, may not receive the latest treatments, and are twice as likely to die than any other patient population with this disease. Outcomes for African American patients may improve with early diagnosis and treatment. If you experience unexplained issues such as bone pain, back pain, or fatigue, talk to your doctor about getting tested for multiple myeloma.
Great, excellent. Thank you so much. Shameless plug. I'm so excited for that video because that is something that we've just finished and we've released it. And today is the first that we've debuted it outside the four walls of Kite. So yay, us. It is my honor to sit here on the stage with these wonderful, wonderful individuals here, our panelists. So we're going to have a little fireside chat. And again, it's just an opportunity for us to have a conversation. Yes, please, that's your mic. Just to kind of talk. Again, we're here talking about, championing for caregivers. Obviously, we're here to support and love on our patients, but we really want to just kind of hear perspectives and just kind of share. All right? So, Ms. McCrae, I'll start with you, if you want to introduce yourself.
So, good evening, everyone, and I'm so excited to be here and to see all of you here. It's not my house, but I do want to welcome you, and I'm glad that you're here to learn more about multiple myeloma. It's my passion. I've been a patient for 17 years, survivor for 17 years, and so for those of you who know that myeloma is not curable, but is treatable, I'm a personal witness. So please ask me any questions.
That's so wonderful. I love, oftentimes we hear multiple myeloma thriver, so that I'm so happy and that you've been thriving for 17 years after your diagnosis, so congratulations. Mr. and Mrs. Price, I'll turn it over to you for an introduction.
All right, my name is Ted Price, and I do very appreciative to have been invited to come out tonight. I am a 6-year survivor of multiple myeloma, and I'm the guy that, as the introduction was, that many times it's a 20-year-old who might get multiple myeloma. Well, at 73 years of age, I came down with multiple myeloma. And believe me, it was a shocker. And I'll tell you more as we go along.
Good evening, everyone. My name is Maddie Price, and I too want to thank you all for having us here. And just as someone said, there are not a lot of people that know anything about multiple myeloma, including myself. I had no idea what it was. And just like my husband said, I have been his caretaker since 2019. Yeah, we've been on this journey since 2019. And sometimes it's easy and sometimes it's not. But we'll talk more about that later.
So one of the things, I'm just gonna stay right here with you two. One of the things I want to make mention is when we first met, Mrs. Price, the first thing you said, and it just resonated so much with me, you said, we were diagnosed, we thrive. So can you share a little bit about that? Tell us about your perspective and your journey.
Well, first of all, he went to the doctor by himself. I didn't go. At the time, I had an aunt that was 100, so I'm taking care of her, and she lives in Athens, Georgia. So he went by himself. And when I got back home, he was real quiet. He didn't say anything. And I'm like, something is going on here. He was quiet for a couple of days, and eventually he told me. And I'm like, well, what is that? And he said, it's a form of cancer. And I think I about lost it then. But I recovered. But then we had to tell his siblings, and that was not a good thing. But we've come a long way since then. I've had to learn medical terms. Been to the hospital. Every time he goes, I go, because I want to know what's going on with him.
And I mean, and you feel that that's important.
It's very important. It's very important to know what's going on, because you have to know my husband. He doesn't talk much, and he doesn't tell you everything. So I want to be there to hear it for myself.
Yeah. Well, I think, man, we're often, especially black men, we're often accused of, one, we don't go to the doctor when like we should, and then two, we're not listening and we're not able to relay the information. So we do need our experts to go with us, right?
Now he'll go to the doctor and he'll listen, but if I'm not there, he probably won't tell me.
Right. So thank you. Ms. McCray, I'll turn to you. If you want to share, again, I'm hearkening back on conversations that we've had before, and you shared how just having a community and being in a group has been very supportive, and you've even become a group leader, because again, you said you've been thriving for a couple decades almost. So yeah, can you share about that?
So I was diagnosed in 2008, and I had symptoms. Many people don't have symptoms, but one of the things I'll share with you is what they call the CRAB criteria. Those are, some things that will help you identify, and they are not necessarily symptoms that are exclusive to myeloma. So the C in the CRAB is for calcium, increased calcium in the blood. The R is for renal or for kidney. That's one of the organs that's impacted by myeloma. The A is for anemia. So, if you're feeling unnecessarily tired and, those kinds of things, then, you may want to look out for that. And the B is for bone damage. And I had bone damage. I wasn't able to stand up. I had severe back pain. And, I'm, a hard-headed person. I've not been sick, so I didn't want to go to the doctor, but I had to. And when I got to my primary, of course, he made all the appropriate referrals for my symptoms. And so, I had an orthopedic referral, an MRI, and rheumatologist, and all of these things. But when my blood work came back, I had excess calcium in my blood. And when I was diagnosed, I found out that I had lost 3 inches of height. So it was the calcium from my spine, from my bones, that was spilling into my blood. I'm not a joiner, and I've never joined organizations. And so my sister, who is my care partner, was looking for information. You're going to do your research, and the research said you've got 2 to 3 years. Of course, that was alarming. And she found on the bulletin board at the clinic information about a support group, and the leader of that support group referred her to someone who at that time was a 17-year survivor. And at this point, that same person has been surviving for 35 years and thriving. So please know that incurable, but very treatable. And for me, if you have to have any kind of cancer, myeloma is one of those things. The research is ongoing. The drug approvals are quick in turnaround, so you have many, many options. But the problem is, how does that information get to the average patient? And that's why I joined the support group. When I went to my first meeting, what I heard was people talking about the specific medications they were on, the dosages they were on, the communication they had with their doctors and their teams, asking for second opinions, going for second opinions. So, you know, I'm saying this is an activated group, and this is a group I can become a part of. And we have 2 groups in the metro Atlanta area. My sister, myself, and a retired nurse from the VA are the co-leaders of the Southside group, but we meet in a hybrid fashion. So anybody can join us the first and or fourth Saturdays to exchange information, to hear what options are available, as Dr. Tuckson referred to, how other people are doing, you know, what is a stem cell transplant, what the heck, you know, do you go through as a care partner with CAR T, what am I expected to do with this thing called BiTEs or bispecifics. So you learn so much information, and you know, I hope that any of you who are here will hear me well enough to say, you know, I want to get more information, here's how I can get it, and you know, and be a part of that.
So it sounds like what I'm hearing, because you mentioned, you said you're not typically a joiner, but you did find joining a support group, being around that community, would you say empowering? And
absolutely empowering, absolutely.
Yeah.
And you know, meaning, you know, wanting to share that with others.
Can I say something about the support group?
Absolutely, yes.
When we first found out about TED diagnosis, we were about, what were we getting ready to do? Sell everything we had. Let's run out and buy you a car. And I'm like, hold on now, we got time, we got time. No, we don't have time. We found a support group, and I'm so glad we did, because the minute we stepped in there, I knew that was the place to be. It gave us hope. We knew that we had time. We had time. And I'm so grateful to them, because it saved our lives.
Yeah.
And to add on to that, I'm a little hoarse here, but I'll try and talk through it. Yeah, the support group really breathed fresh air into me, because everything that I read after getting my diagnosis was that there was a 3 to 5 year span of life left for the average multiple myeloma patient. And that, when you think you have retired, you put a few eggs in the bank, and you're going to relax and just enjoy life. You got this new trial coming before you now. You have something brand new at the age that I was. So once we met and joined the group, and they had a round table as well, and each person gave their background, their journey, and how long they've been on that journey. And my goodness, I heard 9 years, I heard 12 years, I heard 15, I heard 20, and as Gail said, there was one there that's now been there for 35 years. And I really just laid back in my chair and took a deep breath, because no longer was I faced with the end of the road, as you might as well put it that simply. I didn't have to, rush and get the wheel and get Maddie, my wife, all stationary before something happened to me, because they said 3 to 5. You might not have made it to 3. You might have made it the day after 3 years or what have you. But it was a really excellent organization to join, and I would recommend it to anyone who has a family member, if you're not yourself, to get in touch with a support group. There is a lot of information you can learn, and the camaraderie is just fantastic. Just to have someone who understand and share with you what you're going through.
That's great. That's great. I want to make a pivot just a little bit and go and talk about your healthcare provider and the relationship there. Can you share, do you feel comfortable and confident, and how important is that relationship with your healthcare provider, with your doctor?
My doctor? Yeah, right now, I am with A.M.E Winship on Clifton Road. There's 2 Winships now. They just built a new one in Midtown. There's an A.M.E Midtown, just built that one. And it's right next to Crawford W. Long or A.M.E Midtown, one and the same, just next door to it. But I go to Clifton Road. That's where I started out at, and that's where I remain. My doctor there is Dr. Jonathan Kaufman, fantastic doctor. And he also has a fantastic PA, physician assistant. I see more of her than I do of him, but I can just simply ask for his presence, and he'll be there whenever I schedule him to be in to see me. The care at A.M.E Winship is fantastic. They are professionals. They are doctors of myeloma. They are not a general cancer doctor that treats all kinds of cancers. The doctor I see is a specialist and a researcher in myeloma. So I get first-class treatment from my standpoint in that regards.
So I wanted to build on that and say it's very important that any myeloma patient see a myeloma specialist. And in our last month's support group meeting, a new patient said, "Oh, I'm seeing a specialist. I'm seeing a hematologist oncologist." But it's a hematologist oncologist who's not necessarily specializing in myeloma. The myeloma world, as I mentioned before, changes very, very quickly. And it's not that the community doctors, that people don't know how to treat it. It's that more and more information is coming out so quickly. And one of the things from one of the big national and international conferences, one of the conclusions was that none of the medications that are used now with myeloma are used in exactly the way they were used in clinical trials. And so there's trial and error that, as a specialist, you would feel the freedom to go outside of the clinical trial. I think it's extremely important that you have a good feeling about the doctors and the team that you see. The more information you know about myeloma, and people say, ask questions, ask questions, ask questions, but sometimes you don't know enough to ask questions. That's another advantage of a support group, because you hear what others have gone through, and then you say, well, what about that in me, and what about that in me? Know what kind of myeloma you have. The term is multiple myeloma, and it's not like hypertension or some other treatment where everybody gets a similar treatment. Everybody's treatment is more dependent on the type of myeloma they have. So please just ask them, what kind of myeloma do I have, and write that down. I have gone through, as I said, it's 17 years, and after my stem cell transplant, I had 7 years of remission. So, I had freedom for for a long time, and then I relapsed again, and then I've had a recent relapse. As you're trying to decide what the next therapy is going to be, my first time making that decision, I had just an incredible relationship with my doctor. And he said, "What do you think you want to do?" I said, "I've read about this, and I've read about this, and what do you think about this?" And he was one of maybe 3 myeloma specialists at that time. But I wanted to go on some of the newer medication. I was still working, and there were 2 medications you could take orally, so I wouldn't have to go to get, tested and infused and all of those things on a regular basis. So it's, whatever whatever fits what you are doing. And I said, "Well, what about this combination?" And he said, "No, well, it wasn't approved in clinical trial. Let me go talk to the team." They can also talk to the pharmaceutical companies and override some of what is written. So, make sure you have someone in place that will fight for you. I have had to change doctors because I wasn't, in my second relapse, I wasn't feeling overly confident that I was getting all the information I needed to make the best decision. And so again, with myeloma, we say, and I see he's coming up, so I'm gonna, try to corral my comments. I think the general comment is, don't be afraid of asking for a second opinion. The myeloma world is small with providers, with the specialists. They do talk to each other. That's okay. But they do have differing opinions. And I've been to some of the conferences where they were sitting on a stage just like this, myeloma specialists from all over the world. A question would be asked, and how do you treat this myeloma? And each one would have a different response. Okay, so knowing that was comforting for me, that everybody doesn't agree, and it's okay. So you have that discussion, and then you figure it out from there. So
Great. Thank you, Ms. McCray. No, it's okay. Thanks, Mr. McCray. Mr. and Mrs. Price, thank you so much for your time and sharing your experience. We're very grateful to hear it. So with that said, we'll conclude, and we'll turn it back over to you, Mr. Jackson. Thank you.
As everyone is coming down, Mr. Price, you can just answer yes or no from there. Did you ever get that car? It's outside. Oh, you got the car. All right. Very good. Very good. Just had to ask. I was just curious about that because they didn't seem to close that loop, Let's give another hand for our panel. Just wonderful, wonderful. And you can see why I say the fireside chat is perhaps the most important part of what we're going to do. Because it's one thing when physicians tell you something, we listen. But when patients talk, we pay attention, So it's very important to hear that. So we had a very good panel. Next, we're going to move on with one of our speakers, Dr. David Shepard. He will be speaking to us today about multiple myeloma in the Black community. Dr. Shepard is a graduate of the University of Indiana College of Medicine, and he did his residency in internal medicine at Ascension St. Vincent Hospital in Indianapolis. This was followed by a fellowship in hematology and oncology at the University of Michigan. He is currently out of practice here in Decatur, Georgia, and is affiliated with the Northwest Georgia Oncology Center's WellStar. Today he will give us a better understanding of multiple myeloma recognition and managing the side effects as well as the symptoms of this most interesting disease. Dr. Shepard.
All right, thank you. Appreciate that. Thank you so much for the kind introduction. First off, I'd like to say I'm very grateful to be here. Thank you so much for allowing me to share with you this evening. I knew that following the panel discussion, I would have less interest in my slides. So what I'm going to do, I'm going to continue to use them as somewhat of a guide, and then I'm going to kind of just talk to a certain extent off the cuff about multiple myeloma. So I am a generalist. All right, so the bottom line is there's not enough Dr. Kaufmans, Dr. Nukas, Dr. Low-Neals, Dr. Hoffmeisters around to treat all the myeloma patients. Some people are going to see general medical oncologists and hematologists. That's just the very fact of the matter. And I am actually looking at my presentation as a time to give you a lay of the land before you hear some of these specialists tomorrow. They're going to talk to you about specific treatments that you would not be able to get if you were to come to my clinic alone. Okay, so it is important, very, very important, to have very subspecialized medical oncologists and hematologists to treat a varying number of diseases. So if you told me, hey, call Dr. Kaufman, I've got him on speed dial. If you told me, call Dr. Nuka, I've got him on speed dial. These people come to speak to our groups. I send patients that are in need of things that I can't offer to these people regularly. And you are very blessed to be in the Atlanta community where, to be quite honest, it is fairly saturated with both community and academic oncologists. You are going to find special niches when you are a transplanter or someone that can offer CAR T. Those specialists are more limited in numbers, but I thank you. And I also would like to say just how fortunate we are to be talking about myeloma, because certain medical conditions and oncologic conditions in particular have support groups that are very scary and very intimidating. And you go to the support group and you hear about how poorly everyone's doing, how limited their treatment options are. So we're very grateful to be able to talk about multiple myeloma, where when I first started training in 2005 in residency at St. Vincent, as you discussed, I saw my first patient that had a, there we go, that had a x-ray that looked very much like this. And we had a drug combination to offer her called melphalan and prednisone. And it was the exact same drug combination we'd been offering people for the past 15 years. And we told her, hey, your survival is going to be somewhere between 1 to 3 years. This is not curable, but it's treatable. By the time I was at University of Michigan, I was telling people it was 3 to 5 years. Now people come to my office, they sit down, I say on average folks are going to do 5 to 10 years. In 2015, we had 4 myeloma drugs alone. Okay, so this is a drug that, or a field where drugs are progressing rapidly, and a lot of that is due to the understanding of the disease. One of the things that the cancers of the blood allow us to do is to always get tissue, okay? And that is emerging. Some of the solid tumors are catching up, but if I can do a bone marrow biopsy and get new tissue whenever I want without worrying about puncturing your lung or having complications in bone, elsewhere, or puncturing arteries. The tissue has always been very easy to obtain in the hematologic malignancies. So research has advanced faster in these diseases than a lot of our solid tumors, okay? So multiple myeloma, one of the things that the panelists shared was the CRAB criteria. Okay, and we are actually going to talk briefly about the CRAB criteria because I think it's important to understand. And again, what I'm trying to do is lay a foundation so you have an idea of what we're going to be talking about tomorrow. Okay, when you get into much more specified talks about treatment. The bottom line is, why are we here? Well, myeloma affects 2 to 3 times more African American patients than their white counterparts. Amongst people that are affected, it's going to affect men more often, about 1.4 to 1 male to female ratio in diagnosis of this disease. Now, we're going to get into, interestingly enough, some of the causative things, but one of the reasons that, keeps coming up more and more and more and more and more, why are African Americans having poorer outcomes when they do? It's because of later presentations, okay? This is a disease where my colleagues are actually doing an excellent job treating people regardless of race, okay? And outcomes are fairly similar when we correct for how sick someone was when they showed up at the door. So when we talk about who sees who and who gets what treatment, a lot of that is to do with how old you are when you show up, okay? So less than 1% of multiple myeloma patients are going to be under 40 years old. Less than 2% of multiple myeloma patients are going to be less than 50. Okay, so the majority of these patients are going to get diagnosed between the ages of 65 to 75 years old. Oh, yeah, man. I'll get to it, man. All right. So at any rate, that's when the majority of these folks are going to present. And depending on how old you are, that a lot of the time affects where we send you. So if I've got a 40-year-old that shows up in my office with multiple myeloma, I do all the staging studies. I get everything they need done. And then I say, guys, you need to go see Kaufman, and he's going to tell us how best to proceed. And I'm going to give him a call, and he's going to answer the phone or call me back within, a day, and we're going to come up with a plan for that patient. When you present and you're 75 and you've got diabetes and you've got hypertension, all these other comorbidities, well, it becomes less complex because there's less options. And I'm going to treat you the way I know is best for you. And then when we come up to times where you are either not responding or losing a response, maybe we're going to consider clinical trials. If I don't have one at my group, we do have clinical trials in the community. But if I don't have one at my group, then we will go ahead and send you to either the group at Northside, if you're here in Atlanta, or the group at A.M.E, where they are going to be able to offer more specialized treatments. We now have CTCA. You're going to meet a member of their staff, or I'm sorry, what are they called now? City of Hope. We have City of Hope now on the south side, and you're going to actually meet some of their great staff tomorrow as well. So what we have here actually is a skull x-ray, and there's very limited normal skull here. So we've got pretty much this part of the skull remaining that's normal. All these little black lucencies, as we call them, those are abnormal areas where plasma cells are eating into the bone. They're literally eating into the bone, and that's what's going to cause these elevation in calciums and this bone pain that people are going to present with. And again, one of the things here that we need to remember is that the earlier you present, the better you'll be. So the less hard-headed you are, if your back hasn't hurt for 55 years, and you're 56, and now your back's hurt for a month and a half every day, well, golly, there might be something wrong. You got to go get that looked at. You can't wait, okay? Women, boy, I tell you, you superstars, you guys. Oh, I'm tired, but I'm working 3 jobs, and I'm taking care of my grandbabies. I understand that. If you're more tired this week than you were the past 20 years when you were doing all the same stuff, you got to go get looked at. We got to quit giving ourselves excuses. That's what we do. We give ourselves so many excuses not to go to the doctor. Well, this is normal because of this, or this is normal because of that. Well, my rib hurts, but last week I was gardening. Well, what'd you do in the garden you haven't done the past 100 years? Your rib hurts because you've got myeloma in it, maybe. You need to go get that checked out. So we got to do a better job at that. So what we're going to talk about, there we go. So myeloma, defined, epidemiology, we've already talked about that a little bit. Treatment basics, and then I'm going to open it up for any questions with any time we have remaining. I run my mouth, so I don't know how much time is going to be left. We'll try our best. All right, so myeloma. Cancer of plasma cells in the bone marrow. What's a plasma cell? This is one of these conditions where it's hard enough to explain that the primary care docs don't tell the patients anything. They just show up, they say, hey, my blood labs were abnormal, and they told me to come here, okay? And there's very little discussion that's been had about what we are working up. So these plasma cells are cells that make antibodies. They're very important in a normal immune response, and that's why one of the terrible complications of myeloma is infection. People get infections because the cells that are supposed to be protecting them are no longer functioning. They are proliferating and they are making antibodies that are not targeted for anything that would protect them against a virus or a bacteria or a fungus or the like, okay? So these cells they've become malignant and they're dividing in the bone marrow, and they're taking up space. And when they take up space in the bone marrow, you can't make the other cells that you need to make, and that's why patients get anemic. So anemia is one of these symptoms that can come on very gradually, and that's why we've got to pay attention to our energy levels. We've got to pay attention to our levels of fatigue. These are things that we cannot ignore, okay? When these cells leave the bone marrow, they still love bone. So they go to other places and they put up homes in new bone. Oftentimes, that's the spine, and we will see people with fractures in their spine, with height loss, as was alluded to earlier, and then elevations in calcium. So these calcium elevations cause symptoms too, right? So you end up with constipation, right? Well, how often do we ignore being constipated? You don't have to raise your hand. We're not going to tell on anybody. But, I mean, let's be honest. You know, it's not something that when it happens, we particularly worry about it unless we've got another symptom going with it, or we're seeing some blood, or something's really making us nervous about our stool. So these things are all important, man. You got to pay attention to your body, okay? Crab. So getting to crab, and this is kind of going to go over like how we present and things like that. So we've got that hypercalcemia, right? So that's the bone destruction. That's easy enough to understand. When we start talking about renal failure, things get a little bit more complicated, okay? So you've got to picture, you've got this cell, all right, that is functioning in a cancerous way. What does that mean? It means that it's dividing with no breaks. God does not make junk. When your cell sets out to divide under normal circumstances, it's the most amazing, well-controlled pathway. And if you're a cell nerd like me, it's just beautiful. It gets you all excited. It's very well regulated. When a cell becomes cancerous, it has learned to pull off the brakes. It's going to divide and divide and divide and divide and divide, and it's going to destroy whatever is in its way. That's why people pass away ultimately from cancers, because these cells divide, and ultimately patients succumb to disease because they can either no longer tolerate treatment, or the damage to the organs and the vital systems is more than is compatible at that point with life, okay? So when we talk about these cells that are making these antibodies, antibodies have heavy chains, okay, and light chains. They look kind of like, if you can picture the Y in the YMCA, and on the top part, there's a little short chain next to the long one. Those short chains can break off in myeloma, and they can clog the kidney tubules, just like as if you have a clogged, too much hair in your drain. You can get too much antibody in these kidney tubules, and it causes kidney function to decrease, okay? So that's important to look at. So when we talk about advocating for ourselves, right? Hey, my kidney number's off. Oh, it's your high blood pressure. Oh, it's your diabetes. You know, very well could be. But, Doc, how about we go ahead and check and make sure I don't have abnormal light chains? I heard a talk about this thing called myeloma. How about we go ahead and check for that if we haven't, okay? You got to remember, this is going to be 1 to 2% of cancers, okay? So your primary care doctor might not be all that attuned to this either. This is not something they're going to see commonly. There's 36,000 cases of myeloma in the United States every year, okay? So that's important to keep in mind. Anemia. We use hemoglobin less than 10. That's because by that point, you're good and anemic. We're not saying you've got mild anemia. We're not talking about maybe some negligible iron deficiency or you need a B12 shot. You're getting good and anemic, okay? We need to do a bone marrow biopsy and figure out why your hemoglobin is this low, okay? You're probably going to have some fatigue at that point. Again, you can't ignore these symptoms, my friend. And then we get to bone lesions. Newer criteria, right? So the crab criteria have been around forever, okay? So newer criteria are going to include light chain ratios, right? How much of this light chain am I making? This is a clone, right? So you only make one type versus another, okay? And then the percentage of bone marrow involvement. The percentage of bone marrow involvement is actually important because when we talk about myeloma, we talk about a progression of disease. Everybody with multiple myeloma at some point has what we call a monoclonal gammopathy of undetermined significance. That basically means you're making this antibody, but it's not bothering you. You don't have anemia. Your bones are fine. Your kidneys are fine. You've got less than 10% of bone marrow involvement. over time, that clone increases. And when you have more than 10% of your bone marrow involved, that becomes what we call a smoldering multiple myeloma. And that's a higher risk situation than just monoclonal gammopathy of undetermined significance. Once we get to any symptoms or greater than 60% of the cells in the bone marrow, that's when we have full-on multiple myeloma, and that's going to require some treatment, okay? When we talk about causes, again, age is our biggest cause, okay? Genetic abnormalities. So there's some associations with certain deletions on chromosome 3 and chromosome 7 that can be seen in families, but that is very rare. Otherwise, we know that this might cluster in families, but there's not a causative gene that we are aware of. When we talk about chemical exposures, you know, when I first started talking about myeloma, there was a real broad range. And why is it more common in black people? And they talked about perms and hair dyes and all that kind of stuff. They've actually really limited it down. Most of the studies now, correct me if I'm wrong, we're talking about Agent Orange exposure as a huge one for our vets. Thank you to anybody that served, but you'd be at risk for that. Socioeconomic status is not really associated with a difference in terms of white and black outcomes as much as it is being disproportionately associated with later presentations, okay? And again, age, 60 plus is gonna be much more common. African Americans are gonna be 2 to 3 times more common to have this condition than their white counterparts. So, number of deaths per 100,000 persons by race, you're gonna have 7.6 for black males as opposed to 4.2 for their Caucasian counterparts. Our Asian Pacific Islanders see the least amount of myeloma. This isn't projecting well, but this kind of is important in that it's racial disparities at disease presentation. This is basically when you showed up. So when you showed up, who's in the worst shape? And the highest line, which is bright green, African Americans, most likely to have hypercalcemia when they show up, most likely to have kidney dysfunction when they show up, most likely to be anemic when they show up, most likely to require dialysis already at the time they show up. Everything but fracture. Everything but fracture. So we've got to really start paying attention to ourselves, my friends. And then treatments, because I think I'm about out of time. Lastly, treatments. And you're going to get more into detail with this tomorrow, and I hope I've laid a little bit of a foundation. But what I want to say is just that we've got multiple different treatments for multiple myeloma, okay? We've got traditional chemotherapy that's very rarely used these days, only in the setting typically of transplants or people with very, very, very resistant disease. The majority of these therapies are relatively new targeted therapies that are going to affect how the proteins are cycled, how the cell is cycled, how your body reacts to various factors in the bone marrow. We've got drugs like Revlimid, A.M.E, you guys have probably heard of that have been on the panel, that we call immunomodulators. They affect the bone marrow environment. We very commonly use antibodies now against cells that are on the surface of these, or I'm sorry, against markers that are on the surface of these plasma cells. So there's a variety of treatments, and that's why we're starting to get to these very long-term survivors, because we're hitting these cells in a number of different ways. I tell my patients, lastly, you know, cancer, you got to think about cancer therapy when we're in a setting that's not curable, just like you've heard about bacteria and antibiotics. When I talk about bacterial resistant to antibiotics, everybody kind of gets that, right? You expose a bacteria to a drug, eventually it learns how to overcome it. Everybody says you gotta complete your course of antibiotics, right? You can't leave anything lingering because it'll overcome the drug. Same thing with clonal evolution in cancer therapy. So one of the things that's really made multiple myeloma stand out the past few years is all the different ways we're able to target these cells to cause cell destruction so that we don't have overlapping pathways of resistance. Okay, so that is, myeloma in a nutshell. Just all these different targets that we can hit in the myeloma cells. And again, you're going to hear more in detail about that tomorrow. I want to say that was it. So yeah, thank you very much. I appreciate it.
Thank you, Ron. A couple of reminders. At the conclusion of our next presentation, we're going to have everyone up on the up here as a panel, so we have a chance to ask more questions. So if you're thinking about something, I think many of you got little note cards. Write them down, or at least try to remember it, and we'll try to get to as many of the questions as we can. Also want to remind you that in your packets there was a pre-survey. Please fill that out. And then at the conclusion of this program today, fill out the post-survey part. It's very important for us to try to keep information straight. I think one of the interesting things that Dr. Shepard pointed out is there is no pass for procrastination. When you think you got something, what do they say nowadays? If you see something, say something. Well, if you feel something, do something about it, please, if you can. Our next speaker is Dr. Christina Alston Valare. Valere, well, I blew it. Valere rhymes with there. So anyway, Dr. Christina Alston Valere. She's going to be speaking to us today, the role of mental and behavioral health support. Dr. Valere got her bachelor's degree in social work at the College of New Rochelle, received a master's degree in social work at Fordham University, followed by a doctor of philosophy and social work at Barry University. She is currently the psych oncology coordinator for the Northside Hospital and Behavioral Health Department and Northside Hospital Cancer Institute. Of note, in 2015, Dr. Valere was the recipient of the ACS Lane Adams Award, which recognizes individuals who consistently demonstrate excellence and compassion in providing care to cancer patients. Right now, we have a chance to hear from Dr. Valere, who will talk to us a little bit about, as I said before, the role of mental and behavioral health support in taking care of melanoma. Dr. Valere. Thank you, ma'am.
Thank you. Wow, we're hearing a lot of medical stuff from all night long, right? So for me, I want to say this. I want everyone just to take a pause, because we're not talking about medicine right now. We are going to talk about our wellness, right? So for a minute, I want you guys all to stop, close your eyes. Think about nothing but just the moment we're in. And just breathe, right? Slowly, slowly. Okay. And then I want you to exhale one long breath out. And as you're breathing out, I want you to push that stomach area in, okay? So let's take one deep breath where we're in your chair. So you're going to be sort of pushing down in the chair, and your abdomen will go out. And then when we release that, you're going to open wide, release, and push the stomach inward, okay? All right. So let's inhale one deep breath in. Circulating, bringing all the good stuff in. And then let's exhale. Right? Okay. All right. Hope that changed the mood a little bit, because we're going to talk about some stuff that are not medicine related, and I was instructed to go down. Maybe I'm not pointing in the right direction. There we go. All right. So we're going to be talking about exploring the role of mental health and behavioral health, right? And that support is in what? Multiple myeloma care. So that involves folks who have multiple myeloma, but today we're also going to be talking about caregivers and what they need to know and what they can do to help themselves. My first slide, you guys heard all about these things. I think the only thing that wasn't touched was the prevalence of multiple myeloma as it is in 2025, as reported by the American Cancer Society, and they say 162,339 cases was noted in 2025. So that number goes up and down depending on what's going on, mostly up, I would say. If I could find the right place to stand to do this. I got to be in the front. Yeah, I'm doing the down button, sorry. There we go, okay. All right, so I think I passed one slide, so I'll just tell you about that. So when I started talking about this, I figured one of the things I wanted you to know about is the fact of how cancer does impact us, and in particular, our multiple myeloma, right? So a cancer diagnosis, I always say, can be overwhelming because it affects so many parts of our lives, right? It doesn't, I'm sorry, hold on one second. I thought I had this off. I had it on. There, okay. All right. It affects all our systems, right? And so this is one of the reasons why it's important to understand what you're going through and to get the support for that. Now, normally I think of it as the response that you might have for this. I want to think about it sort of like a grief reaction, right? Because initially when you get that diagnosis, you may be in shock or disbelief, right? You're like, that can't be happening to me. You might even go into a stage of feeling angry about it. I've done all the things I should be doing. I've lived a good life. I've eaten well. I've worked. I've done this. I've done that. Then, of course, you get to a place where you might begin to feel a little bit sad and depressed and down. And then, of course, you know, you work through that some kind of way, sometimes with help. Sometimes you do it by prayer, going to church, speaking with your church sisters or, you know, somebody you trust, and that might help you. And then hopefully you get that resolved. Of course, we know that cancer is affecting now not just our physical body, but our mental, our social, financial. We know that there's a lot of financial toxicity in the care of cancer, and multiple myeloma is no different. Family, your interpersonal relations with others, because so much is happening to you, you're sometimes sort of withdrawing. Sometimes it's impacting our spiritual, right? You're saying like, where is God in all of this? So I wanted to say that all of that is quite normal. And I think initially everyone feels like they get hit with something like this and they retreat. And they think that no one else in the world is having this. And this is not that's not the intellectual part of you, it's more the heart, right? Because we know that there's lots and lots of cancers, different types of cancers, as well as multiple myeloma. But when it hits you, you begin to think that it's only me. And so I say that to say this, that this is the time when I want to encourage people here in this room to be thinking about, you know, how do you connect with others? You heard on the panel that Mr. Ted had his wife, right? And of course, Ms. Gail had her sister. And then that circle grew as they began to get more outside of themselves. I think I will do this. Oops, I wanted to get that, hold on. Okay, so what are some of the emotional stressors that you might encounter as a patient, right? So I have a long list, but I want to say most of all that you might feel some sadness, right? Some distress, depending on where you are in the stage of it all. Sometimes even some loneliness, right? People get isolated as they're trying to deal with everything. They might even have some guilt that maybe they did something in their lifetime that could have caused this. And then there's a lot of uncertainty and depression. So I won't read the whole list, but those are some of the major ones that you see, right? The anxiety, the depression, the overwhelming need to sort of isolate themselves, the uncertainty of it all. And I mean, it's understandable, right? This is something major that you're dealing with. So it's understandable that you would feel that way. And then you're getting news from the doctors that might say 1 to 3, 3 to 5 years. Certainly that's impacting you in the way you think about stuff. Okay, so what are some of the concerns? So I want to say that when I meet a patient and they tell me that they're fine and they don't have anything to worry about, I begin to worry because I think that there's always something that you would worry about, right? There isn't, I mean, I just can't imagine not having anything to worry about. So if nothing else, you heard Mr. Ted say I was first of all, worried about my wife and getting her situated. And everyone has something or someone or some set of things that they're concerned about, right? And immediately you're beginning to think of the things that you have not done yet. Oh my goodness, my daughter's going to get married next year. Will I be here? I'm waiting to retire. I've worked hard. Will I get there? Or now you're here and you may not get there. So there is always something that you're thinking about, all right? So the worry, the uncertainty, sometimes having sleepless nights, ongoing, as you're thinking and thinking about this in the night, it could stop you from having that good sleep, which you definitely need. Irritability, right? Lack of interest in things that you once had interested in. And then at times, you may not even feel like communicating that to anyone. Again, the encouragement is to tell you that it's okay to tell people around you how you're feeling, what you need, because they're on the other end trying to figure it out from that side. And if you don't tell them what you need, you won't get what you really need, right? And you might think that people just don't care, when indeed they do care, but they're feeling like they don't know how to help you either. So we want to help them to be able to help you. The other thing I want to say is, and I said that before, but I can't help but say it again, and that is quite normal to feel like you are, you know, having sort of like an or an unbelievable situation, right? You cannot even fathom how this could have happened. And so that's normal. It's normal to have some anxiety, which is that increase in it, you know, in the stress within your system. And it's okay to feel depressed. I also want to say that it's not uncommon to have these things happen because it's a way of coping, right? The mind is a wonderfully powerful tool, and it knows exactly how to help us. And sometimes it brings us down a little bit so that we could sort of get back up on our feet. And other times, it may not quite know what to do. It doesn't know how to read you, so it does its own thing. And so that's when you really want to be able to make sure that you're reaching out. You can talk to your treatment team, the doctor, the nurse, the PA. You can talk to the social worker. That's my training by profession. You can certainly talk to your nurse navigator, the dietitian. Anyone on your team is someone that you can talk with. And so I want to empower each of you to be able to think along those lines as a patient, but also as a caregiver. Never be afraid to ask your treatment team what you need to do or ask about what you would like to hear about, because they're there to help you. I'm going to go up. Let's see if I can get this to move. There we go. So I wanted to talk about a little bit about patients being the heroes, all right? They're the ones going through all of this hardship, and sometimes they're quiet, sometimes they're not, sometimes they're irritable about what's going on, but they're the ones that are mastering this disease. And so I want to, again, say this, because I want each of you to feel empowered as a patient, to speak up and to ask for what you need. We know that this disease is impacting you physically, practically, financially, emotionally, in every which way. And while you might see on the statistics there, that has already been said about how many people are diagnosed annually and how many people are living with it. So I'll go by that really quickly and go to my next slide. And let's see if I can get this to work. Did it go? No. I think I passed it. Okay, all right. I am sorry I'm having such trouble with it, but I will stand in front of it. This way I think it'll be better. What? Oh, yeah? Oh, perfect. I love it, I love it. Thank you. Okay, I think I went too far just now, and I passed my slide after that. Can you go back to that? Oh, no, that's right. Okay. Next, please. Okay. This is way better. Why weren't we doing this before? I should have asked for what I needed. See? You see what happens when you don't ask? All right, I made the point with myself. So now, caregivers. I only have a few minutes, so I want to make sure I cover this. So you're feeling this roller coaster ride yourself. You're on it with your patient, your loved one. And so it's quite normal to feel all of these things, right? The stress about, oh, I'm going to get all this stuff done, depression, the anxiety, the anger about it. And I'll tell you something, the guilt, the loneliness. Sometimes the person that's sick has not always been that nice to you either. And now they are sick and they need you. Talk about how you feel, right, about that. Because you know you're going to have to help them, but you have to go through some things yourself in order to get there in a nice way. Next slide, please. All right, so you guys are the unsung heroes, right? You're holding on the fort. You play a vital role in the treatment process for your loved one. As a caregiver, your task. You have many tasks. You do a lot of physical things, and it's impacting you in a physical way, a lot of practical and emotional things. And you see the statistics that was done in 2016, so it's way more caregivers now than that 40 million that we see there. But the thing I want to say, and you could go to the next slide, please, is that as a caregiver, you tend to not pay as much attention to your own self, right? I can't tell you how many times when I was in practice, doing more practice than I do now, because now I don't see as many patients. But when I used to do that, I would have many times, I would have caregivers come to me later on, and they themselves now have cancer, but they were so busy taking their own person from appointment to appointment that they didn't even take care of their own, right? And so this sometimes this thing that you don't think about, it's okay to ask for some help because you need some respite care yourselves. And I think that you might think that or feel guilty about that. But in order to really take care of your person and yourself, you're going to have to get a little me in there. So as you're thinking about your person, I want you to say, knock your chest if you're a caregiver now, and say, I'm important too, right? All right, so you're going to take care of yourself as well. And just like the patients, you are experiencing all these behavioral health things, right? You're having some depression, anxiety, et cetera. And I want you to be able to get that help. Now, a lot of times we talk about mental health and behavioral health, and we use them interchangeably, but there are some differences, and I want to show that to you now. So when you talk about mental health, it really is focusing on the psychological component of your being, and that's in the mind, right? And your emotional state that you're in. And mental health is more about the thoughts and feelings that you have, right? And how they affect you. And then behavioral health is more like a bigger term. It's a bigger umbrella. So it takes in this component of mental health, but it also takes in the behavioral aspect of it all, right? So let's say, for example, you are somebody, you could be so overwhelmed with everything that you then begin to maybe smoke more cigarettes, you begin to do other things maybe you didn't do before, or maybe these things are pre-existing, whether you're the patient or the caregiver, and they get exacerbated. In other words, it blows up and become much more unmanageable when you put a multiple myeloma diagnosis on top of what you already have. Maybe you already had issues with substance use disorder. Maybe you already had a history of depression or anxiety or post-traumatic stress disorder. And then now you have to incorporate cancer with all its different tentacles in your life and on your person into this. And if you're not presently getting any kind of behavioral health support or mental health support, tell me what you think will happen to you. I heard something. It gets worse. Just like how the cancer grows and grows unchecked if nobody stops it, then your behavioral health or your mental health just continues to go on. And what it does, though, it complicates the capacity for the person to either successfully complete their treatment and by adhering to it, and it stops you, the caregiver, from being able to provide the care that the person needs. So guess what? When you come into the clinic, if you're so dysregulated, you're the person now as a caregiver or even as the patient that's taking the time, because now they have to look at what's keeping you from doing what you need to do. Okay, next slide. All right, next slide. And this is a whole bunch of different things. I sort of touched on some of them already, so we can go. What's mental health, like your perception, your identity, your emotions, and a little bit from the behavioral health side, the way you react to things, your habits, your lifestyle. All of these things are more in the behavioral health umbrella, your cultural practices, and your coping mechanism. Next slide, please. So we are encouraging both patients and caregivers to really connect to their behavioral health services. And each of you, as long as you have insurance, or even if you do not, you have access to behavioral health support, right? Your insurance is one piece, but if you don't, you can get that through your local office, your local county offices. Next slide. So we want you to be able to think about how you're coping, right? And so some tools of acceptance, right? We do like deep breathing, you do massages, you do meditation, yoga. All of these things are wonderful ways to help yourself. But most of all, I want to point it from this list that you need to think about just where you find help, and then try to get some meaning into all of this. What's the meaning behind all of this? And how can I move forward to help myself and help the patient? Next slide. And some intervention. So we heard about support group, that's one. And then, of course, that could be general or it could be as specific as the multiple myeloma group. But there are caregiver groups as well. And so if you look, even if you Google it, you could see what's local. The Cancer Support Community has a bunch of things like groups, and caregiver group is one of those. We can provide supportive counseling while you're in treatment, the social worker that's working with you. Certainly you can get individual psychotherapy or group psychotherapy. And then, of course, medication. So that sometimes, not everyone that's experiencing some of these symptoms need medication, but then there are folks that do. And so when you do, I want you to think about it just the same way as you would think about getting medication for your high blood pressure or diabetes. It's, you know, it's something that can be managed with medication and interventions. Substance use disorder, there are clinics where you can get help with that. Those are the intensive outpatient clinics. And then, of course, for those folks who have not really addressed what's going on and they get to the place where they feel like life is just too much and they're thinking about ending that, I want you to also know there's a 3-digit number, 988, and that's the National Suicide and Crisis Lifeline. And then, next slide. And these are just ways that you can chill out as a patient, right? Take care of yourself. And the next slide. So different things, right, that you can do. I think that is pretty much the end of that. Yeah. Thank you.
Seat up there. And thank you very much. I'd like to bring back our panel. The Prices, come on back, Ms. McIntyre, come on back. Dr. Shepard, come on up if you would, please. I just want to break a little bit for a moment. Yeah, the community of caregivers is very strong, and the dedication of individuals who provide this care is very, very strong. So one of our speakers for tomorrow is not going to be able to be with us because she has to attend the funeral of her uncle. So I want to give recognition to Ms. Kim Lindsay now, who provided care for her mother with multiple myeloma. She was kind enough and she's dedicated enough. Yeah, give a hand for her, please. This young lady is so dedicated for us that she did a video so she could get her words to inspire the rest of us and guide the rest of us. So I don't know how you do it, Ms. Lindsay, but thank you very, very much. I just want you to know we're appreciative of everything. If you have a question, if you've written it down on a card, just pass it to one of the HEAL people. If not, just raise your hand and I'll come around to you. and we'll do this. While we're waiting, or while you all get over your shyness about asking a question, because the point was raised about the importance of seeing someone who may be a melanoma specialist. Now, mind you, I'm a colorectal surgeon, did a lot of, pretty much did most colorectal cancer. But to be quite honest about it, most colorectal surgeons, general surgeons, could do most colorectal stuff that I did. So, is it more important that we have a good oncologist or that we have someone who is a specialist in melanoma? Meaning a good oncologist, someone who knows what they know and knows what they don't know and needs call. Let me ask you that. I want to start off first from the psychological perspective, because sometimes we, in this era of mistrust, we say, well, does my doctor really know, and are they really telling me the truth? So tell me that, please, and then we'll come to you.
So I will always say this, that I think it is so important. Oh,
Yeah. Just push it up.
Can you hear me? The light's on, so that means you can hear, right? Yeah, it is so important in your care that you're connected with someone that you feel that trust in, that you feel that confidence in the work that they're doing with you. I say that first because I think that's important, because the person that's caring for you, you're gonna have that person with you for a long time, or hopefully a long time. So it's important that you have a good rapport with them, that you can ask questions and feel like they not only hear you, but they respond, so that if you need something, for example, if you brought to them that, hey, I heard something at the melanoma talk last night, and I heard all about this MGUS and the other ones and, and all the therapies, and I want to have you check more along those lines for me. Is that something you can do? You want to trust, number one, that they can say, hey, I know quite a bit about, hematology stuff and cancer and stuff, but I don't really know that, but I know where to go. Like you said, you have the person on speed dial. You can contact those specialists. You know where to connect them to get any kind of treatments that you know that you yourself can afford. And often, even if, let's say, you get referred to a specialist, and sometimes we used to sometimes send patients out of the state for specialized treatment that they've heard about. But the good thing is that the physician, if it's a good physician, will be willing to work with that specialist, wherever that specialist is, to provide you with that care, that treatment that they recommended, so that you can do that at home instead of being somewhere far, right? Or having to switch between doctors. Your doctor, if he's a good physician caring, can be able to give that same treatment to you. Because not everyone has access to specialists, right? So if in your little town, all you have is the good hematology oncology specialist, then you start there and you will get referred out as you need to. But you also need to be a good advocate for your care.
Ms. McRae, go ahead, please.
So I do want to backtrack, and you started it. It's not melanoma, it's myeloma.
Myeloma, I'm sorry, excuse me. Yeah, I did do that, didn't I?
And so I don't think you need to do one or the other, and Dr. Shepard mentioned it. I think there are so many myeloma patients, and the myeloma specialists can't take care of everyone, but I think it's important to see a myeloma specialist, close to the beginning of your therapy, and get that relationship with the local hematologist, oncologist, so that there is that partnership and relationship and collaboration, and so that you as the patient and the care partner are getting the best possible treatment from all of the providers. And I'll mention while I have the mic that it's important not to just rely on your physician, but the rest of that team is so well trained, and you need to be able to talk to them and ask questions and all of those things. They know what they're doing. And so, we've had some patients to say, I want to see my doctor, I want to see my doctor, and it's not always necessary. And so.
Ms. McRae, I'll tell you that I have another for you. As a colorectal surgeon, I once had a patient tell me, Dr. Tuckson, I like you, but I know you're not too bright, otherwise you'd been a heart surgeon. So my saying melanoma instead of myeloma is par for the course. But Dr. Shepard, You mentioned somebody that's got a kidney problem that they may want to mention to their nephrologist or their primary care physician who's doing the lab work to say, okay, check for light chains or check for immunoglobulins. But so what? So you do this test. What do you do with the information?
I think that it's I'm speaking from being in Atlanta. Again, we're very blessed in this community. I've got very good relationships with our special. Prior to my current position, I worked at Winship. Like we're a small community. I feel like when you speak out and say, hey, how about this next level of testing? All you need is the result. That's really all you need. If the result is abnormal, you go to plan B. If the result is normal, then you're done with it. You know, I think we tend to make things sometimes as patients a little bit more complicated than they really are because the medical system is such that we are reacting to these same things every day. I think one of the things that's very isolating for patients is that you are always an N of one. You know, that's what makes the support group so important. But, you know, the guys that refer to me for abnormal SPEPs might send me, 20 patients a quarter for abnormal SPEPs, these abnormal proteins that they see. So they know where to go when these things are found that are abnormal. They know how to get you to the right place. And to the point of the small guy in, wherever, Alabama, that doesn't have anyone to rely on until you drive 2 hours to UAB. You know, the main thing about that person is that you've got to have a relationship with them. At the end of the day, you can be treated at the ivory tower of any disease. If you don't have a good relationship with your provider, if you don't have trust with your provider, you're not going to have the desired outcome. So relationships, I think, are very important, and making sure that you feel like you can communicate with your doctor, I think, is more important than really anything else. One of the things, we've got all these fancy treatments I've mentioned that you're going to hear about in detail tomorrow. We don't have reverses. So the cancer card goes straight, it goes right, it goes left, but it doesn't go backwards, right? So you've got to be in communication with people so that you can understand why the decisions are made that are being made. Real quick, because I left one thing out in rush when I was giving my presentation.
Blame me, sure, go ahead.
This is very important. Weight, BMI. I didn't mention BMI. So BMI and being overweight is a risk factor for myeloma and MGUS development. 44% of African Americans are overweight by their BMI, 35% of white Americans. And just to make sure that we're on the same page, I'm gonna stand up and be very honest. I am technically obese. This is what obesity looks like. We're not talking about morbid obesity, okay? This is obese. I'm working on it, all right? That's where we're at.
All right, but it's interesting that you talked about obesity. And that's a good point, because we do know that when you look at some of the risk factors, if we talk about risk factors of multiple myeloma, and perhaps we'll get into it more tomorrow, but family history, et cetera, et cetera. But there is environmental factors. In particular, particulate matter 2.5, which we know causes inflammation. And I believe that the obesity is because inflammatory response associated with obesity is what gives rise to this. And also, you mentioned Agent Orange, but also benzene. Comment a little bit about that, and then we're also going to get further comments.
So basically, we know that benzenes are associated with hematologic malignancies. The chemicals, a lot that we spray on our food, Roundup and things like that, they're associated with hematologic malignancies. And I mean blood cancers when I say that, and all types of blood cancers. I think that it gets a little bit harder to nail down myeloma specifically as a cause, but when we group these things together, they definitely increase the risk for clonal or cancerous blood disorders. Benzenes we've known about a long time because they contribute to acute leukemias. But we see other blood cancers. Again, insecticides are huge. Other environmental pollutants, you know, they're theorized, but they're not proven, you know, beyond a reasonable doubt. And I think that when we start talking about what are our risk factors and deciding, well, I can't move here, I can't move there because of this, we've got to be very specific.
One
So
of our
I think
speakers
that's
for tomorrow, Dr. Brandon Blue, the same thing. Talk to us a little bit about environment, because it seems like when we talk about this increased incidence and mortality in African Americans, it can't be our genes, or can it? Or is it more of our zip code as opposed to our genetic code?
Yeah, so, you know, I think really like anything, how's everybody doing? I'm Dr. Blue. I'm one of the cancer doctors down at Moffitt Cancer Center down in Tampa, Florida. But, and I'm also one of the multiple myeloma doctors. But basically, when it comes to this disease, it's basically you try to figure out, is it nature versus nurture, right? Is it something that your mom and daddy kind of passed down to you, or is it basically being a product of your environment? The thing that makes it a little bit tricky is that maybe your mom and daddy may not have passed it down as far as your DNA, but y'all grew up in the same household, y'all grew up in the same neighborhood, y'all, your cousins and everybody else, y'all grew up eating the same food, right? So it makes it a little bit difficult to tease out between the two. Some things that we do know, like for example, the firefighters who were in 9/11, a lot of them end up getting blood cancers, right? People who went over to Vietnam and got exposed to the Agent Orange, they end up getting these cancers. People who are in something called Camp Lejeune, which is another military base, they also were drinking some water that was contaminated. People who were over in the Middle East, they had these big burn pits. God only knows what they was burning, but over time they ended up getting cancer, right? So there are things that unfortunately you could be doing in your 20s and 30s that unfortunately may develop when you're 50 and 60 years old, because we just didn't know and things just come up, you know what I mean? So for sure, there are a lot of things that are happening, and we'll learn more and more about it, but that's my 2 cents.
Thank you very much. So to that end, Mr. Price, you mentioned that you had some siblings. So tell me about that discussion. You get the diagnosis of multiple myeloma. Please note I said multiple myeloma. You would get the diagnosis of multiple myeloma. What is that conversation you had with them, your siblings?
Yes, it was very important that I passed the information on to my brothers and sisters, just to see, had I missed anything or had they not told me anything that might be going on in their particular lives. That happens quite often. But anyway, I had all my kids, my brothers and sisters, to come to my place, and we had a dinner. And it was to be, and I told them before they got there what we were going to do. Come and be honest and be open. And that's what they did. And there was no indications of anyone having any blood issues from a blood cancer or what have you. So it seemed as if, but however, I am a veteran, a Vietnam veteran. Mm-hmm. Mm-hmm. And I don't know if I picked it up there or not. It was in I was not in a heavy combat zone. However, once they start spraying for Agent Orange to kill the foliage in the area, you don't know how far that chemical will float in the air. But I was there for just less than a year, but it doesn't take long. But I couldn't prove it, but I did file a claim with VA just to be on the safe side.
Yeah, but how many of your brothers and sisters went out? You heard Dr. Shepard tell us, get tested. How many of your brothers and sisters, based on what you told them, went out and got tested?
There again, I can't say. All I could do is suggest and recommend that they go out and be tested. They all have doctors, primary care physicians, and what have you. Mm-hmm. All I can do is just tell them to go out and be tested.
Thank you. I got to tell you, one of the things that's most impactful, and we've heard, is, and particularly those who you in healthcare will know, you mentioned the word cancer, and I guarantee you, only 20% of whatever is said afterwards. It's almost like those Charlie Brown cartoons. Blah, 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 blah. From that point on, nobody is hearing what we say.
Yeah.
So the question comes, but when it finally hits them, we say cancer, and though you've already talked about it, correct me, 60% 5-year survival rates, or a little bit longer right now. We're cancer, we all think we're going to die. Now, we've already heard with melanoma, but multiple myelomas, see, you got me in my head. Just like I can't say, I'm terrible. But anyway, once you get that in your head, you think you're going to die. So the question that comes to me, what is the role of the pastor in this? When a member of your flock comes to you and says, hey, I have this diagnosis, number one, why do I have it? Because I'm a good person. And B, what's going to happen to me?
Thank you for putting me on the spot here. All right. I was just hosting the meeting. I wasn't on the panel. But it is a very valid question, good question. And I always believe that there is these intersections where medicine and faith come together. And certainly I've sat with many members having this conversation. I want to always acknowledge a person's feelings and what they are dealing with in that moment. Never discount how a person's feeling and know that everyone handles this very differently. I am, as a pastor, I never try to be God in that moment or to give them a definite answer as we don't know why. In fact, I oftentimes tell folk, well, the Bible has a lot of why questions that are never answered, you know. Even Jesus had a why question and really wasn't answered. Why have you forsaken me? But in prayer and in faith, every person comes to know their why. They ask God, and in faith, they'll get to it. They'll come to that reason. It could be many, many reasons. God has a purpose in everything. It's what we try to reinforce. But as a faith community, we're here to help you get through it, And so that's my role as a pastor, to be the support, to always point a person back to their faith and to let them know that all those Sundays you've heard me preach or all those times you've studied the word, this is the time where you're going to need it right now.
Usually when I hear patients, they talk about faith, they always say, well, I remind them of the story about the flood when the sheriff warned them the flood was coming. They came around to the house, they come on and leave before the floods comes. They sent a boat around and the floods coming and the person says, no, God's going to save me. The person's on the roof and the helicopter comes and they say, no, God's going to save me. And they die and they go to heaven. And they asked St. Peter, said, how come y'all didn't help me? I'm a good, faithful person. He said, who the heck do you think sent the sheriff, the boat, and the helicopter? There's a roll for docs. Yes, ma'am. Stand up, please. Or you can stay there and look cute. Here you go.
My name is Pamela Hill, and I want to tell Pastor thank you very much, because as you just asked about the pastor a question, I did go to my pastor. I was in a lot of tears. I was stressful to learn that my husband had cancer. I want to thank Dr. Shepard. I never met him. But when me and my husband went to him, my husband got kind of angry before because I go with him to the doctor. I ask questions because, as they were saying, sometimes they don't tell us nothing. I ask questions. One day I got mad. I wouldn't go in. Next thing I knew, they came and got me. I said, well, he didn't want me in there. He said, I asked too many questions. I'm going to be there until death do us part. But I just want to say, and to you, Miss Price, I heard you. I have tears in my eyes every day. My husband do get angry. I got to learn to shut up when he get angry. I got to learn to listen to him. But as a care provider, it hurts. but I got to be strong. Not too long ago, our church had choirs came from North Carolina. I wasn't going to go. I was mad at my husband. I jumped up. I told one of the lady next to me, I said, I'm crying, but my tears are not out. Them people sung songs I needed to hear. And for everybody in here, whatever you're going through, there's a man upstairs. And he knows everything we're going through. Man say, but God got the last word.
Thank you very much. I guess when it comes to being a caregiver, you have to follow the advice of the late the late representative from Georgia, John Lewis. Cause good trouble. Cause good trouble. With that, we're going to bring our program to an end. I know that there are probably more questions now that we said we're going to bring this to an end, but all good things must come to it. There's a beginning and there's an end. There's an alpha and there's an omega. No, you hold that thought. So I want to bring back Pastor, if you'll come up and you'll bring us to the end of our program. I will point out that our people will be around, so please come up and talk. If you want to get the names of any of the physicians or the healthcare workers, please feel free to do so. They'll be more than happy to give you their number, and they really love it if you call them about 2 or 3 o'clock in the morning, and I encourage you to do so. But having said that, and going to incur the wrath of Ms. Price, which I'm going to have to deal with. Mr. Mosley, you want to come up and say a few words, and then we'll bring the pastor to end us out.
Let's give Dr. Tuckson a hand. It's not easy to stand up here and drive programming, and he's done a great job at it. I know I called him crazy earlier. You see, he's a great guy. Let's give this panel a great hand too. I just want you all to know that Dr. Shepard kicked off our program. When we started our organization 6, 7, however long ago it was, we started one of our first programs in multiple myeloma, and he was the physician that we picked to help bring this information. He's grown up so well. I'm just so proud of you, sir. And then again, Pastor Morrison, you the man, son. I just appreciate you. And let's give him a big hand. Letting us use your house. A couple of housekeeping things that they told me I have to do. So first of all, you all have folders. Bring them back tomorrow when you come with you, because we only brought enough that the information for, see, I should let her come up and do this. The information for tomorrow is in there. The survey, you got the survey in there. Do those. Anything else I miss? Because I follow instructions well now. That's what they do. They tell me where to go, and I go. And food. We got some food left? Get some food. Who didn't get any food, take some with you. Thank you. Thank you for letting me. Well, first of all, wasn't that great? Wasn't that food great? It was outstanding. And that key lime cake, we're not gonna talk about that in there. But that was awesome. So, oh, you got your information cards? You got, give them to me. Yeah, after the program, I'll be glad to take, and we'll answer your questions for you. But no, we want you all to come back out tomorrow. This is great programming. As you can see, it's a lot of information. We didn't want to do it all in one day. That's why it's doing it in 2 days. That's why we want you to get this information in pieces so you can digest it. It'll be hard to sit here for 4 hours to try to get this, but this is really about bringing this to you. We're also going to provide you with a great lunch afterwards. So just like you had that great food today, you're going to have that tomorrow. So it's going to be an outstanding program. Pastor Morrison, come take us out of here.
Thank you. Let us bow our heads. Gracious and loving God, to you who is the great physician of our souls, we pray, Lord, and we thank you for all of the information, this fellowship tonight. We thank you, Lord, for your presence that is among us. We ask you now, God, to dismiss us from this place, but never your presence. Grant us a restful night, safe travels home, and safe travels back here for part 2 on tomorrow. For it is in your name we pray. Amen.